Food deserts explained. Why your zip code predicts your life expectancy. Two neighborhoods, 3 miles apart, same city. One has 4 grocery stores, a farmer's market, and a life expectancy of 83 years. The other has a gas station, 2 fast food chains, and a liquor store, and a life expectancy of 66 years. 17 years of human life. Decided not by genetics, not by choices, by a zip code. This is not a social media talking point. This is a documented, measurable, physiologically traceable public health catastrophe, and today we are going to prove it, step by step, from the grocery store to the grave. Defining the problem. What is a food desert? The USDA defines a food desert, formerly called a low-income, low-access area, as a census tract where residents are both below a poverty threshold and live more than 1 mile from a supermarket in urban areas, or more than 10 miles in rural areas, without reliable vehicle access. By that definition, the most recent USDA data estimates that 53.6 million Americans, approximately 17.4% of the entire U.S. population, live in low-income, low-access food areas. That number has grown, and the research published in the Journal of Urban Health in 2023, analyzing life expectancy data across 67,138 census tracts, found that the life expectancy of the 47 million Americans residing in food deserts is more than 2 years lower than for people living in high-income areas with easy grocery access. 2 years is the population average. In specific cities, the gap is catastrophic. A 2025 CDC analysis confirmed that in Chicago, the most geographically segregated major American city, life expectancy between neighborhoods just miles apart varies by up to 30.1 years. Washington, D.C. and New York City show gaps exceeding 27 years. These are not statistical abstractions. They are human lives, measured in decades, divided by geography. And food access sits at the center of that divide. The inflammation pathway. How nutrient poverty triggers systemic breakdown. Here is the biological mechanism, because this is not just sociology. It is physiology. When access to fresh produce, lean protein, and whole foods is structurally blocked, what fills the gap is what is available: ultra-processed foods, high in refined carbohydrates, added sugar, trans fats, and sodium, and critically low in fiber, polyphenols, omega-3 fatty acids, and micronutrients. This nutritional profile drives chronic systemic inflammation through a well-documented molecular pathway. A diet dominated by refined carbohydrates and saturated fat activates the nitrogen monofluoride kappa B transcription pathway, a master regulator of inflammatory gene expression, elevating circulating levels of interleukin-6, IL-6, TNF-alpha, and C-reactive protein, CRP. The 2024 Scoping Review published in Advances in Nutrition, synthesizing 65 studies across 43 dietary indexes, confirmed that diets with the highest dietary inflammatory index scores, characterized by low fiber and micronutrient density, showed consistent inverse associations with inflammatory biomarkers across diverse populations. In parallel, the absence of dietary fiber depletes short-chain fatty acid production by gut microbiota, particularly butyrate, which normally maintains intestinal barrier integrity and suppresses systemic inflammatory signaling. When butyrate declines, gut permeability increases, and endotoxins from gram-negative gut bacteria enter systemic circulation, a process called metabolic endotoxemia, triggering a secondary wave of low-grade inflammation. The Atlanta Meta Health Study, which directly analyzed food desert residents, found that compared to non-food desert residents, food desert inhabitants had significantly higher hsCRP levels, lower glutathione, the body's primary antioxidant, and measurably greater arterial stiffness, an independent predictor of cardiovascular mortality, even after adjusting for traditional cardiovascular risk factors. This is chronic inflammation driven by structural food scarcity, operating at the molecular level, in real time, in real bodies. The cardiovascular kill chain. Chronic low-grade inflammation is not an abstract health risk. It has a specific cardiovascular endpoint, and the data is explicit. The 2024 county-level analysis published in the Journal of General Internal Medicine, covering cardiovascular mortality data from 2017 to 2019, identified food desert residents and food insecurity as independent drivers of community-level cardiovascular mortality disparities, above and beyond traditional risk factors like hypertension, smoking, and diabetes. The Atlanta Food Desert Cardiovascular Study found that food desert residents had a 44% higher risk of myocardial infarction compared to non-food desert residents in the same metropolitan area, a finding that held after multivariate adjustment. The mechanism is direct. Chronic nitrogen monofluoride kappa B activation and elevated IL-6 accelerate endothelial dysfunction, damage to the inner lining of blood vessels, promoting the formation of foam cells from oxidized LDL, triggering atherosclerotic plaque development, and increasing the risk of plaque rupture and acute coronary events. Additionally, the refined, high glycemic diet characteristic of food desert nutritional environments drives persistent hyperinsulinemia and insulin resistance, independently promoting hypertension through sodium retention, dyslipidemia through hepatic triglyceride overproduction, and direct cardiac structural remodeling. Food insecurity rates in the United States reached 13.5% of households, approximately 18 million households, in 2023, the highest level since the COVID-19 pandemic disruptions. The JAMA Internal Medicine study published in January 2025 found that food-insecure adults at age 50 had an estimated 2.5 fewer years of remaining life expectancy compared to fully food-secure adults, independent of other confounding variables. The cardiovascular consequence of food desert residence is not a hypothesis. It is a documented, graded, dose-dependent relationship between structural food scarcity and early death. The racial geography of food deserts. Food deserts are not randomly distributed across American geography. Their location follows a pattern that is inseparable from the history of racial segregation and structural disinvestment. The Atlanta Food Desert Study found that 52% of food desert residents were Black, compared to 34% in non-food desert areas of the same city. Multiple national analyses confirm this pattern. The most recent USDA food security data from 2023 reports that non-Hispanic Black households experience food insecurity at a rate of 23.3%, more than double the 9.9% rate for non-Hispanic white households. Hispanic households face food insecurity at 21.9%. These disparities map directly onto the life expectancy gap that CDC data, published through 2025, now confirms for the third consecutive year. Black Americans have a life expectancy of 72.8 years, compared to 77.5 years for white Americans and nearly 85 years for Asian Americans. Research has found that life expectancy can vary by as much as 20 years depending on race, ethnicity, and neighborhood, a gap that is widening despite medical advances. The cause, as a growing body of evidence makes clear, is not genetic predisposition. It is the physical environment, including and especially the food environment, that structural segregation has created and maintained. The zip code is not a proxy for race. But in American urban geography, they are deeply correlated, and the physiological consequences of that correlation are written in decades of lost life. Cancer and cognition. The expanded damage. Cardiovascular disease is the headline, but it is not the only organ system being destroyed. A landmark study published in JAMA Oncology in July 2023, by Bevel et al., found that food desert and food swamp residents were significantly associated with obesity-related cancer mortality in the United States, including colorectal, endometrial, and kidney cancers, after adjusting for socioeconomic and demographic factors. The California Cancer Registry study, covering over 113,000 breast and colorectal cancer patients, found that food desert residents had measurably worse 5-year survival outcomes, 78% versus 80% for breast cancer, and 60% versus 64% for colorectal cancer, despite receiving equivalent rates of surgery and chemotherapy. The environment, not the treatment, was the differentiating variable. Cognitive decline is emerging as another documented consequence. The National Health and Aging Trends Study, linking food desert residents' data from 2010 to 2021 follow-up cognitive assessments in 5,270 adults over 65, found that food desert residence was associated with accelerated decline in orientation, executive function, and memory over time. Black and Hispanic older adults living in food deserts bore a disproportionate share of this cognitive burden. A zip code should not be a death sentence. But right now, measured in years of life, in cardiovascular events, in cancer survival rates, in cognitive function in old age, it functionally is. The physiological pathway from food desert to early death is not a theory. It runs from an empty refrigerator through nitrogen monofluoride kappa B activation, through foam cells on an arterial wall, through a failing pancreas, through an oncology ward, and ends where it was always structurally destined to end, early. The research is settled. The mechanism is mapped. The mortality data is irrefutable. What remains is the political will to treat food access as what it actually is: a medical intervention, as important as any drug, any procedure, any clinical protocol. Because the most powerful determinant of your long-term health is not the hospital you can reach in a crisis. It is the grocery store you can reach on a Tuesday. Subscribe for more lectures at this level of depth. Real data, real mechanisms, real stakes. Every week.